Hello everyone and welcome to all. So my name is Katalin Lugosi. I am a neurologist in Bajcsy-Zsilinszky Hospital and my PhD topic is the cognitive impairment in multiple sclerosis. My supervisor is Zsolt Mezei. He is a neurologist also in the Department of Neurology, Semmelweis University. And our vision is to assist in planning further researches and selecting the most appropriate care in MS cognition. And our mission is to better understand the specific patterns of cognitive impairment in MS with the aim of improving the management of patients experiencing this condition. And to achieve these goals, we have two main meta-analyses. The first one is a cognitive impairment in different subtypes of MS, and the second one is an association study, association between patient characteristics and cognitive screening test results in patients with MS. So I will talk about the first project, cognitive impairment in different subtypes of MS. First of all, a few words about the background. So what is cognition? Cognition is our way of thinking, and it consists of five main neurocognitive domains: the memory function, the executive function, attention or information processing speed, the language function, and the visuospatial perception. And we can measure all of these cognitive domains by neuropsychological tests. You can see here examples of these neuropsychological tests. There are several ones, and we have chosen these ones. This is altogether the brief repeatable laboratory of neuropsychological tests. We have chosen this one because this has a high sensitivity and specificity. And what is multiple sclerosis? It's a chronic neuroimmunological demyelinating central nervous diseases, which has four main clinical phenotypes. You can see here in this picture the clinically isolated syndrome with the initial first and isolated attack at the early stage of the disease. The common form is the relapsing-remitting multiple sclerosis with relapses and remission period between relapses. And the progressive forms of MS, the primary progressive with the continuous neurodegeneration from the beginning, and the secondary progressive MS, which develops from the relapsing-remitting form. And the problems. Cognitive impairment is common in MS and has a significant impact on quality of life, but it is not routinely screened, and most clinical condition scales do not include assessment of cognitive function, so it is a fact and a gap. And the prevalence and pattern of cognitive domain impairment in different MS subtypes are unclear, and the thresholds of cognitive measurements are not standardized, so this is also a problem in the literature and in this field. And therefore, our aim was to investigate the prevalence of cognitive domain impairment in different MS subtypes using subtests of a predefined neuropsychological test battery, as I mentioned previously. You can see here a colored picture, by analyzing the different cutoffs used to define as pathological. Why? Because this is crucial for well-designed neuro-rehabilitation programs and comparable cognitive studies. Our clinical question is, what is the prevalence of cognitive domain impairment in different subtypes of MS? Here you can see our COCO-POP framework, and the condition was the distinct cognitive domain impairment, the context, different clinical subtypes of MS, and the population, the adult patients. The systematic search and from the three main databases. Initially, we had more than 10,000 articles, and finally, we had 48 articles for the review, 40 for the meta-analysis, and 8 for the systematic review. And here you can see our results. We have three main forest plots. It's a quite busy forest plot, but I'm going to explain it. So. You can see here the prevalence rates of cognitive domain impairment, and these are the neuropsychological tests, as I mentioned earlier. And this one is the different MS subtypes. At the 1.5 standard deviation cutoff, you can see here at the top of the figure. because we found that there are three main cutoff measurements, or cutoff scores in measuring of cognitive domain, the 1.5 standard deviation below the mean of normative value, the 2 standard deviation below the mean of normative value, and the 5th percentile below the mean of normative value. I mean the cognitively healthy population. So the main findings are certain degree of impairment can be observed regarding all the cognitive domains within each subtypes. And it means that it must be screened routinely, so it must be included in the clinical condition scales. The most pronounced form was the progressive forms, especially the secondary progressive multiple sclerosis. The exception was the verbal fluency, which was highest degree in primary progressive form of MS. It's a main finding, and it's a new finding. Information processing speed and attention affects 1/4 of RRMS patients. Information processing speed was more mildly impaired in PPMS group compared to the RRMS form. And it leads us to the conclusion that we must highlight this patient with cognitive rehabilitation as patient at risk, increased risk. And clinically isolated syndrome as the initial form of MS, less severely affected among all subtypes is. And it means that we must follow this patient for subsequent cognitive impairment before it is detected. And finally, the cutoff values, as I mentioned, the cutoff values of 1.5 standard deviation and 2.0 standard deviation below the age and normative education mean was the most frequent thresholds in the literature. And it leads us to standardized set of criteria must be established for comparing further cognitive studies. Strengths, it was the first meta-analysis with involved patient with clinically isolated syndrome, and the limitation it's a main limitation that we disregarded the variations of clinical and demographic parameters underlying the test results due to the lack of sufficient relevant data. Manuscript status, it has been reviewed at neurology for more than a month, but it has been rejected. And now the next journal is the Annals of Neurology. So the second topic, association between patient characteristics and cognitive screening test results in MS, it's also a meta-analysis. Background, as you remember, I showed you a picture, a colored picture, with the 5 main cognitive domains. And we are interested in the attention function, information processing speed. It can be measured by the SDMT test, the Symbol Digit Modalities test. It is a cognitive screening test. It is a recommendation. And you can see here the test itself. So you must match the symbols and the digits all together. And the point, the score is the overall point of matched symbols. And, but we don't know the extent to which clinical and demographic parameters influence the test scores, and therefore, although identifying this association is essential to accurately assess test results and to highlight patients at risk with significant factors affecting the test. The project status is we are at the protocol registration phase, but we have selected the articles and it's a feasible topic. So for summary, with this meta-analysis, we will give detailed mapping of cognitive impairment in multiple sclerosis, and we hopefully will answer the question, how does the cognitive screening test correlate the clinical and demographic parameters? We have presented our first topics results at the annual conference of Neuroimmunological Society. So thank you for your attention. With Aldous Huxley's words.
I just, congratulations, first of all. I mean, with your progress. I mean, that's always a kind of pain when you get a rejection from a journal. I mean, I experienced that many times, actually, so that may happen. So can I ask, actually, a general question about this? So when you get the rejection, so did you get a detailed reviewer opinion on this? And whether, So how much can you use that when you renew the paper?
Yes, thank you. We have received very detailed review answers, and it's very, very valuable for us. And the main problem or the main findings from the reviewers were so that we ignore the clinical and demographic parameters. So these are confounding factors at the results, but we ignored. So this was maybe the first problem with this, and we must manage somehow this problem. And maybe we will recreate the statistical approaches with somehow deal with the confounding factors. Because there was a study at 2008 from Greece, and they found that the EDSS score, this is the very common measurement scale in the physical status of multiple sclerosis. So it has a highly impact on the cognitive function. So if we ignore the EDSS score, for example, it can distort the findings, the results. So yes.
Thank you. Another issue, maybe I don't know whether it was mentioned in the reviewers, that with what I miss here is social cognition. You mentioned the 5 areas of cognition, and we know that social cognition is very much in connection with functionality and quality of life. And there are studies also from Hungary by Professor Zsolt Illés on the relationship, on the problems of social cognition in multiple sclerosis. I don't know how many other studies there are, and maybe it's enough for a meta-analysis or not.
Yes, there are a few, but there is an existing meta-analysis on social cognition anyway.
And what about the results?
Sorry?
And what about the results? I'm curious.
Sorry, I don't know exactly.
You don't know?
But it's difficult to measure social cognition. It's always mentioned in the literature. And the most commonly used neuropsychological test batteries don't include the social cognition, because there is not an exact neuropsychological test to measure it. So for example, SDMT test is a very high sensitivity and very sensitive test for measuring information processing speed, but it's different in the social cognition.
Yes, you are right. There are many ways and many tests. And did you mention in the discussion, or do you plan to mention this problem of measuring social cognition? Maybe
Not
it
yet.
can help your paper. If you
Thank you.
put
Thank
a
you
short
for your
emphasis on this.
suggestion. Yes, we will consider.
I would like to ask you, Kati, that what cognitive rehabilitations mean, and is it available in Hungary? Maybe it is a better question for Professor Tényi.
Sorry, cognitive recommendation?
Rehabilitation.
Rehabilitation, sorry.
And is it available, and is it an effective method to...
Yes, thank you. It's a difficult question, but what does it mean, cognitive rehabilitation? Yes. So first of all, we must detect the cognitive impairment somehow, and it is the first difficult problem. And after, you must preserve your cognitive reserve somehow, or the patient's cognitive reserve somehow. But what does it mean, cognitive reserve? So we can measure it in a very complicated way, yes. And there is no very well designed and pre-specified neurorehabilitation programs. So everybody says that neurorehabilitation programs, yes, but what does it mean? I think it means that the patient must hold their position in vocational status, in meritage status somehow, and so must do physical activity, and must being well conditioned as well as in physical and in mental cognition, but it highly depends on the patient itself, I think. So yes, but neuropsychologist can train the patient as well.
I'm not going for the wine, no. Kati, just my personal curiosity that you presented your results twice on a Hungarian, on 2 Hungarian conferences.
No,
right?
sorry. The first one is in the last year, and so in September 2023 will be the next annual conference. Will be.
My question remains the same. Why didn't you? Is there a particular reason why didn't you try international conferences? I mean, your results are nice and sound, you know. I would definitely go for that.
Yes, thank you. To be honest.
And it also helps you because you get the reviews basically immediately.
So to be honest, I don't feel my results very strong. So I feel the confounders, the problems of confounders, and first of all, we must manage these problems. So I think.
Boost your confidence.
Okay, thank you.
Okay, so thank you for this talk. You mentioned the results about the differences between the different subtypes of MS. And I'm curious that is there a difference in the localization of the MS plaques in these subtypes? Because you measure the different cognitive domains which are related to different cortical regions. I know MS is a subcortical disorder, but I'm just curious. It's a theoretical question.
Yes, thank you. So first of all, MS is not just a subcortical disease, it's a cortical also. So there are several brain deviations, deviations. The overall brain loss, the cognitive, the atrophy of the cortex, and the different demyelination plaques in the different areas of the brain. And we don't know exactly what is the main problem in the cognitive impairment, but maybe, and the main suggestion in the literature is somehow like a disconnection syndrome. So the connection of the cortex and the connection of the subcortical regions. And of course, in the memory problems, the hippocampus and the mesiotemporal regions, and the executive function, of course, the prefrontal cortex and so on. But we don't know exactly. So, what are the plaques for example, in the RRMS forms that relates to the different types of cognitive domain impairment? So it's unclear yet in the literature as well. Yes.
I was just wondering, and again, I have no idea of what you guys are talking about here, but just trying to make common sense. Is there, you have 4 subtypes of MS, right?
Yes.
Do you have different treatments for the 4 subtypes, or is it all the same treatment?
No, different treatments, options.
And do you know the effect of the treatments on the variables you're measuring?
Yes, but there is an existing meta-analysis also, the effect of treatment on the cognitive functions in MS.
So there is?
There is an existing, yes.
So basically what you're measuring here is the interaction of the effect of treatment and the effect of the disease on the outcome variable, right?
No, we didn't investigate the treatment, the effect of treatment.
But aren't they treating the patients?
Yes, if the study...
So then the outcome is basically the effect of the treatment and the MS.
Yes, it's also, it's again confounding factors. So I said that this is the limitation. And the clinical and demographic parameter and the treatment as well, yes.
And you don't have that many papers because
Not many people, but these variables have not been mentioned in these studies exactly or in a comparable way. We discussed it with the statistician, and he said that we cannot make associations with different clinical parameters because sometimes it doesn't exist in the given study. Sometimes they declared, but so we cannot compare. Cannot.
Okay, so basically the most important finding is a big knowledge gap then.
Yes.
That this has to be addressed somehow and there has to be data collected that where these can be measured altogether.
We have to recreate our clinical question somehow. So maybe.
I mean, I wouldn't, okay, it's up to you guys. I would never adjust my question to the result. I would say that the result is what we have and these are the conclusions. Mm-hmm. Okay, thank you.
First of all, thank you for your presentation. I have a comment in first that you talk about and the so-called cognitive rehabilitation that was mentioned, that the cognitive activity, to encourage cognitive activities or physical activity, it sounds very, very simple, but it has a very huge effect. There are randomized controlled trials to measure the effect of this, and the results are highly significant. I just wanted to mention this. And my question is, I assume it's low, but how strong the correlation between the motor function or the decrease of motor function and the cognitive function, or did you measure it?
Yes, thank you. And we don't know the exact answer, but maybe it's not an exact or not not an exact correlation, because so they are independent from each other sometimes. So we can measure the physical condition with the EDSS scale. Is a very commonly used physical measurement scale, but there are a few articles which deal with the connection or association with the EDSS score and cognitive function, and it is unclear because so we at the later stage of the disease, it's a clear correlation. So after the 3.5 score on the EDSS score, it's a clear correlation that the patient has a very significant physical state, physical disability, and also a very significant cognitive disability. But in the initial form or below the 3.0 EDSS score, we don't know the exact association. This is a 0-10 scale measurement, the EDSS score anyway.
The goal is to catch the patient as soon as possible, I guess.
Sorry?
The goal is to find the patient as soon as possible.
Yes,
so
and hold the patient below the 3.0 EDSS score with the treatment.
I see. Thank you.
Okay, so a couple of questions, but first the comment. You said you are not confident with your results. You first sent to JAMA Neurology, which is number 3, then you sent to Neurology, which is number 12, and then you now with Neurology, which is number 9. Impact factors were just published. I have them here. Out of 211 journals, you're not confident. Mm-hmm. Okay, so be confident.
Yes.
Then the question. For this BRBN, what is the time needed to conduct it, and so how much time do you need to do it?
1 hour, 1.5 hours.
Uh-huh.
Yes.
Okay.
And it requires a trained neuropsychologist.
Neuropsychologist?
Yes.
Right.
So we only...
So not really doable in daily practice.
That is the reason that we use the SDMT test as a cognitive screening test. It's a quick one.
And in your review, meta-analysis, all the studies use the same instrument?
Yes, the
Because
BRBN test battery.
Okay, because that is then additional inclusion criteria.
Yes.
You didn't mention it.
Yes, sorry, yes, it was an inclusion criteria.
At the end of the day, how many studies were included due to the fact that they didn't use something, like some studies, or shall I put it in another way? All the studies also had the subtypes of multiple sclerosis.
Yes.
Okay. How much time do you need since diagnosis to determine the subtype? How much time? 1 year, 2 years, 5 years?
So there is a very clear guideline, not a recommendation guideline, the McDonald guideline. So I think it's nowadays it's not a very high-level action, but there are some cases which are difficult. But because of the
But
clear
generally speaking,
guideline,
1 year, 2 years.
I think within 1 year. Within
Okay,
1 year, we
1 year.
must decide.
The reason why I'm asking, how much did you dilute your primary idea with these additional criteria? So, how many studies failed to enter the meta-analysis because they didn't have long enough follow-up, didn't use the instrument you preferred, and so on? Because that is the question for clinical practice.
Yes. But for example, the primary progressive form, the guideline says that at least 1 year of progression needs to define this condition. So in this case, at least 1 year.
At least 1 year. How many studies did you exclude due to these limitations?
Extra studies?
Yes. Yes, because you have identified, I don't know how many, if you can go to that slide, because it's not in the paper or here, what we have shared with us. So, for instance, you had 100 studies, and then 80 would fit your idea, but due to additional criterion, 79 were excluded, so you ended with 1 study. So I would like to know what proportion how much filter did you apply, and how applicable is that for clinical practice? Because if you included like 10% of potential studies, then I'm not happy. If you included 60, then I'm happy. If you have any idea about it.
Yes, it was an additional exclusion criteria, the previous form of McDonald criteria, not the 2070, this is the latest, but the previous one. So if we include those patients with McDonald criteria at 2005 and 2010, maybe it gives us more patients. So yes, thank you.
Yeah, I'll stop.